Next slide. Yeah, Northern Chest and Throat, for those who aren't aware of us, there's essentially four aspects to our work. There's we care, we prevent, we research, and we campaign. We care, we run care services for people who have experienced stroke, or people who have respiratory conditions, and we're building up a service looking after people with cardiac conditions. We prevent in that we are involved in public health promotion. We do health checks for organizations and individuals out in the community, and we run a schools program as well. We research, we sponsor research at the two universities here in Northern Ireland every year, again across all three conditions, and we campaign. We basically try to raise awareness of conditions and raise awareness of the issues affecting chest, heart and stroke with the politicians at Stormont and the people and the civil servants in the Department of Health. And the fifth one that isn't up there is we fundraise, because obviously without the support of the public, we wouldn't be able to do any of it. And 90% of our finance comes from public donations. So I'd just like to spend a few minutes speaking about the asthma campaign. We're started in the last few days. It's aimed at three different audiences. The first audience is school age people, and that's basically to try and put a positive spin on the fact that people have asthma. It's basically to say that if you take your preventer every day and use your inhaler when necessary, that you shouldn't be daunted by the prospect of having asthma. That by using the inhaler and using your air chamber spacer, that you should be able to participate in activities like all the other kids at school. Our second audience is the teenage audience, and obviously the messages for the teenage audience are slightly more hard-hitting, because we're trying to reinforce people. It's during the teenage years that people seem to get out of the habit of using the preventers and get out of the habit of using their inhalers, their reliever inhalers when necessary. So we're running a campaign. This campaign is running on social media. It's running. It will be running on billboards, and a campaign is also started on radio on Cool FM. The third final audience that we're also addressing is the parents, obviously, because many parents, once they've been a diagnosis of asthma, have a tendency to downplay the seriousness of it. Obviously, nobody wants to worry their children unnecessarily, but it is important that people realize that unfortunately people do die of asthma, and of those deaths, 2 out of 3 of them were preventable. So just to reinforce to parents that, to avoid a tragedy, we need to make sure that people use their inhalers every day and carry the reliever wherever they go. So that's the campaign that we've been working with the clinicians from the Children's Hospital to get those messages into a format that we hopefully will gain traction with the public out there. So with that's just quick background on that. And now on to the main event. I'll pass you over to Dara O'Donoghue, who's a consultant paediatrician and senior lecturer at Queen's.
Thanks very much, Neil. So as Neil says, my name is Dara O'Donoghue. I'm a paediatrician in the Children's Hospital, and I've been working in the difficult asthma clinic for the last 10 or 12 years, along with Professor Shields. So we've been looking after the most difficult asthmatic children, and I hope we can pass on a few messages or look at really factors that impact on difficult asthma. I'm very proud and very pleased to be asked to be part of the campaign. And I think there are 2 clear messages that we want to get across from the campaign. First of all, that asthma can kill children. And secondly, that in many cases, or most cases, asthma deaths are avoidable. If we look at what asthma is, first of all, and then we can look at the best way of treating it or dealing with it and caring for children and indeed adults or adolescents with asthma. We know that asthma is the most common long-term condition or chronic condition in children, affecting about 1 in 11 children. That equates to approximately 36,000 children with asthma in Northern Ireland. So it's really, really quite common. the causes of asthma, or what causes the problem with asthma, is inflammation in the airways. And this causes swelling of the airways, which blocks or impacts on the airflow in and out of the lungs. And this causes a blockage to this airflow, which results in the noisy breathing that we hear. This inflammation is caused by a number of recognized triggers. And in 75% of children with asthma, these triggers are well known. Commonly, viral upper respiratory infections can cause asthma, and that's why we see a spike in asthma come the autumn and winter months. Also, exercise can drive or worsen asthma. And this is really important because we know that if exercise is a factor in someone's asthma, then we can address that. We can pre-treat prior to maybe playing football or going for a run, or have our inhalers ready for after the period of exercise. Also, air pollutants can cause exacerbations or flare-ups in asthma. We know that the common symptoms of asthma and how to recognize an attack is when we see children who are short of breath, coughing, and have wheeze. And I think it's really important also to clarify what a wheeze is, because there can be a bit of confusion around a wheeze or crackles or rattles. So a wheeze is a high-pitched whistling type of sound. So it sounds like this. And it can prolong, the breathing out phase can be prolonged because the lungs are trying to squeeze air out of them because it's so obstructed. Unfortunately, we know that in the United Kingdom, which is obviously a very high income or well-to-do country, we are amongst the worst countries in Europe for asthma deaths. And if we look at this Nuffield report that was published in 2018, comparing asthma deaths in adolescents and young adults in the UK with the rest of the world, the top graph looks at asthma deaths in children aged 10 to 14, and the lower graph looks at an older population of people aged 16 to 19. And we can see that only New Zealand has a worse asthma death preponderance or ratio than the United Kingdom for children aged 10 to 14. And only Australia, United States and New Zealand are worse than the United Kingdom for the older age group. So for a well-to-do country, this really isn't good enough. There are a number of lessons that we can learn also from research done into children and adults who have died with asthma. And if we look at this report, the National Review of Asthma Deaths that was published in 2014, it looked at the number of children and adults who had died with asthma over a 12-month period. Over that period of time, as you can see, 195 people died. And there were clear messages that came through from that report that we should use in our practice. Firstly, that children and adults not using their preventer inhaler on a regular basis were at greater chances of having an asthma attack and subsequently dying from asthma. Also, we know that regular follow-up in an asthma clinic is really important. And in this report, only 43% of children and adults had been reviewed in an asthma clinic in the previous 12 months. Also, it's important that parents have a roadmap or a plan for looking and addressing asthma and how to treat asthma. And it's really important that we give a personalized asthma plan to parents to allow them to do this. And we know that only 23% of people who died with asthma in this report had a personalized asthma action plan. We want to focus really on the basics of asthma care. We know that inhalers are useful. We know that they work. However, they don't work if we don't take them. So it's really, really important that we look at adherence to inhaled medication. For many years, when Professor Shields and myself were in the difficult asthma clinic, we were told that by parents, that children were taking their inhalers because parents wanted to please, they wanted to make us feel happy and make us feel that we were doing a good job. But it was transpired that many children were actually not taking their inhalers on a regular basis. And as we've said, if we're not taking the inhalers, they're not going to help the lungs. Also, what's really important is that we use an age-appropriate device to deliver the inhalers into the lungs. So there's no point in using a metered dose inhaler without an aero chamber in any child, really, because to coordinate a metered dose inhaler is extremely difficult, even for an adult. So it's really very important that we use an aero chamber. For very young children, we would use an orange or yellow aero chamber. Over the age of 5, we would use a blue aero chamber, which has a mouthpiece instead of a mask. What is also important is inhaler technique. And for that reason, it's important that children and adults are reviewed on a regular basis in an asthma clinic to check inhaler technique, because we know that we can improve inhaler technique, but we know that it decays over time. So it needs to be refreshed. So these are all real basic parts of asthma care, but really very, very important. And we know that less than 50% of children in Northern Ireland with asthma are receiving the basics of asthma care. We know that there are preventer inhalers, as you're aware, and reliever inhalers. The preventer inhalers should be taken every day, and they have inhaled steroid in them. Why that is important, because this addresses the inflammation that is driving the asthma and helps to soothe the airways, to unblock the airways and open them up. So preventer inhalers should be given usually twice a day. And an example of a preventer inhaler is the Turbohaler, the red and white breath-activated device on the right-hand side. Relievers are obviously important in the event of having an asthma attack, and they're the focus of the personalized asthma plans that provide a roadmap to guide our asthma care. The personalized asthma plans are important because they provide this guidance and allow self-management, which is an important part or an evolving part of asthma management. Because children and adults are not being reviewed so frequently, especially with COVID and the impact of COVID on care generally, it's really important that parents have the tools to be able to manage asthma themselves, or feel confident to be able to manage asthma themselves. And the personalized asthma plan allows this. You can see on the right-hand side a personalized asthma plan, and it's designed to follow the traffic lights. So green, amber, and red. The green section is what children should be taking when everything is good and they're well. When they become more unwell with shortness of breath, cough, and wheeze, the amber section guides what to take, and that usually focuses around stepping up the blue inhaler. And then the red section focuses what to do when children become more acutely unwell and have severe tugging in, severe shortness of breath, and are breathing very quickly. And it also gives advice about when to seek help as well. So what a primary part of the asthma plan is recognition of an asthma attack, because it's only when we recognize that a child is having difficulty and having an exacerbation in their asthma that we can treat it. The primary symptoms, as we've said, of asthma is the cough, breathlessness, and noisy breathing. Usually a wheeze, this high-pitched breathing out sound. We can also see children tugging in And this can be a manifestation of asthma or a flare-up in asthma, where we see tugging in under the ribs and maybe just below the chin and above the clavicles. So the asthma plan should allow us to, first of all, recognize an attack and then respond to it, and then guide when to seek help in out of hours or the emergency departments. The inhaler technique is really important, as we've said as well, and how to give an inhaler. An age-appropriate device, as we've said, is extremely important, and we've got pictures of the yellow aero chamber with a face mask, and this is a holding device that allows us to optimize and increase the amount of inhalers getting to the small airways where it's really important. The upper diagram or upper picture is of a blue aero chamber that we use in children over the age of 5 or so. That has a mouthpiece, and again, it allows us to increase the delivery of inhaled medication into the lungs, where it can start opening up the airways and dampening the inflammation. There are a number of steps in inhaler technique that we should follow, and the asthma nurse specialists are going to go through these in the next 20 to 30 minutes, because if we follow these steps, again, we can hopefully help ensure that the inhaled medication is getting to the lower airways where it's going to work. Asthma review should be a primary concern of anyone with asthma who has asthma. We want to, upon review, we want to review the inhalers. Are they the right inhalers? Is it the right dose of inhaled medication that the child is receiving? And also, are they using the right aero chamber? So as a child gets older, they'll transition from using a yellow aero chamber to a blue aero chamber that has a mouthpiece, and older children can use quite well. We want also to review triggers and exposure to triggers. So that may be allergens. So if a child has an allergy to cats or dogs, and they have cats or dogs in their home environment, then that may be something that we need to address. Also exercise as well. If somebody has exercise-induced asthma, we want to ensure that they have access to their inhalers pre and post-exercise. We also want to ensure that inhaled medication is available in the school environment as well, because if a child is running around playing football or running around the playground and has an asthma attack, it's really essential that school teachers have access to inhaled medication to try and settle and address the asthma attack. We want to look at inhaler technique in the review, hopefully at least annual asthma review. Because of the decay that we've mentioned already in inhaler technique, we tend to maybe become a little blasé. So it's important that we refresh that and improve inhaler technique. And the asthma nurse specialists are really good at doing that. We want to review the personalized asthma plan. As we've said, this is the roadmap for self-management in the home environment. We want to ensure that parents, A, have a plan, but B, and most importantly, understand the plan, understand when their child is having an attack, and understand how to respond to them in a timely way. Also, in the clinic, we can organize breathing tests if appropriate, and over the age of 5, or girls over the age of 4, because girls are always a bit smarter, they can do breathing tests. We can monitor airway inflammation. We can look at lung volumes to see if there's evidence of obstruction to breathing. We can also do we can also do allergy tests if there's a concern about perhaps allergy to cats or dogs, or if there's hay fever, we can look for evidence of allergy to trees and grasses. So we can do those investigations in a timely way in the clinic. So now at this stage, I'll pass you over to our asthma nurse specialists who go through a lot of the steps and a lot of the factors that we've mentioned already over the last few minutes.
So just give me a wee second to get the shared screen down, okay? Thank you.
Hello, my name is Barbara and I'm a paediatric respiratory nurse at the Children's Hospital. And this is Daisy, who is going to demonstrate how to use a turbo inhaler, which is often used for children with asthma. So when you're at your review, as Dr. O'Donoghue said, you have your personalised asthma plan. And in this case, Daisy requires to report 2 puffs twice a day. So Daisy will hold the turbo inhaler. She will twist the top off. She will hold it up like a rocket, give it a click at the bottom, one way and back again. Okay, and then Daisy's going to blow out, pop the inhaler in her mouth and give a big sharp breath in and hold it for 5 seconds. 1, 2, 3, 4, 5. Regardless of the age of the child, we would encourage to use fingers because where we want it to be 1, 2, 3, 4, 5, it's over in a second. But using fingers is a good coach. If Daisy needs to take another pop, she will do another click. Breathe out, pop it in her mouth, and a big suck in. 2, 3, 4, 5. Because the preventers have steroids, which help to damp down symptoms and helps to prevent an asthma attack, the side effects of steroids can cause oral thrush. So then what Daisy would do after taking this inhaler is she would take a drink of water or brush her teeth just to clean her mouth out. And then she'll pop the lid on. Okay. So should Daisy then be feeling tight of breath, short of breath, and feeling a bit of a wheeze, as Dr. O'Donoghue has demonstrated, then we would then follow our plan again. And this is then going into the next section. So initially Daisy would then be taking her blue inhaler. It's white just to pretend, okay, usually it's blue, okay. In this case for Daisy's age, we would use the blue aero chamber for her age, okay. So first of all, I'd be calming Daisy down and going, she's going to be okay. We're going to get your inhaler and hopefully it'll help with symptoms. And initially what we would do would be to give her 2 puffs of the blue inhaler. So first of all, what I'll get Daisy to do is give it a shake. Take the lid off. And get Daisy to breathe out. Bearing in mind she's feeling a bit tight as well. Okay, pop it in her mouth. And this time it's a slow breath in. Daisy, if you could turn it aside just so you can show people. Okay. And squirt. And a slow, deep breath in. And Daisy is going to count her fingers again. 1, 2, 3, 4, 5. She's going to repeat this again now. Again, so give it another shake, Daisy. Breathe out. Suck in. Hold it. 1, 2, 3, 4, 5. This step can be repeated up to 10 times with an interval of 30 seconds in between each puff. And if Daisy does not settle down, she will need to be medically assessed either A&E or with her GP. That's all. Okay.
My name is Catherine Russell, and I'm one of the paediatric asthma nurses in the Children's Hospital at the Royal. This is Eve. She has had asthma for a number of years, and she's 9 years old. So this would be the normal space where we would use for children up to about the age of 5. Once they understand the difference between breathing out and sucking in, we tend to move on to a mouthpiece spacer. However, we're going to demonstrate two.
Can I just ask, we get
Eve.
Eve into the picture there, please?
Sorry.
So talk again, you guys talk again, we'll get the camera focused on you.
Okay. So we're just going to do a demonstration of 2 different types of breathing. Firstly, we're going to use the mask spacer. And this is a tidal breathing technique for children who can't do a single breath and hold or know how to hold their breath.
Clap your hands.
Can you clap your hands for a second? Camera. Position. This is the mouthpiece or the face mask spacer for each age group. As Barbara said previously, we need to shake the inhaler 4 or 5 times in an upright position before we place it in the back of the spacer. This is to mix the propellant and drug. It's really important to do that, or you'll be giving a different dose each time. We place it in the back of the spacer and apply the mask to each space. It's really important that each chin is slightly elevated, either in a neutral position or slightly elevated as if sniffing the morning air.
Can you move the other way
sorry.
towards Barbara?
There we go. And Catherine, maybe if you kneel down slightly, it's just to get the camera to follow your voice.
Sorry. Don't worry. It's important that the face mask fits the spacer, or the mask fits the child's face, creating a good seal. And that there's a valve evidence here is moving back and forward. This shows that the drug will be able to get into the airways. Eve's old enough to understand how to do a breath out, so encourage your child to do a breath out into the inhaler through their mouth. I press the device at the end of the breath out and encourage Eve to take a long, slow, steady breath in. The tidal breathing method requires you just to breathe in and out. 5 to 6 slow, steady breaths is generally recommended by the manufacturer. Some research would be states that in the child over 2 good breaths will clear 1 dose. 2 slow, steady, deep breaths. The most important part of this procedure is in the first 2 seconds. 2 to 3 breaths will get the majority of the dose, up to 40%. 9 breaths will get 41%. So in a child that's reluctant to keep the face mask on, 2 good breaths will clear the majority of the dose. We'll remove the mask from the child's face and wait 30 to 60 seconds before we shake the inhaler again to mix the dose. It's important to wait to give chance for the drug and propellant to settle before you mix it again, or you will be getting a different dose each time. Eve's old enough to also use the mouthpiece spacer. This is better. It's not inferior to use a mask if the technique is good. However, with the child that can use the mouthpiece, they get all of the drug delivered down into the airway, where the mask has some dead space. So some of the drug will hit the skin and some will go down into the airway. If we just want to do the tidal breathing method, or just breath in and out. So again, we shake the inhaler 4 or 5 times, holding it in an upright position, and we place the device in the back of the spacer. The mouthpiece here is placed inside, in between the teeth and the lips, creating a good seal. Again, we'll encourage Eve to do a big breath out, to empty her lungs so she can do a slow, steady breath in. And just breathe. Eve will breathe in and out 2 to 5 times. This is a useful technique if the child is acutely short of breath and having difficulty and cannot do the single breath and hold technique as demonstrated by Daisy previously. Again, 2 to 5 slow, steady breaths through the mouth. Remove. Thank you.
Great, thank you very much for everybody's participation. I'm going to try and move on to the questions. I'm just wondering if you can.
Yeah, we do. If you want to either unmute yourself to ask questions, or if you want to drop it into the chat, we can read it through there. Okay. Does anybody have any questions for the panel? Okay, Dara, can you read that? Sorry, my glasses.
So I'll read this out if that's okay. A few days before lockdown, our 3.5-year-old was given brown and blue inhalers by his allergy consultant due to signs of asthma being present at his appointments. He uses his preventer every day. Nobody has ever said the words he has asthma though. Is he old enough to know if he's asthmatic? I've never had an asthma appointment official help post-lockdown, so it feels so feel clueless. It's a good question. There is no 100% test for asthma, so no gold standard test. The diagnosis is based on the cough, wheeze, shortness of breath, so typical history in response to typical triggers. So that would be, as we said already, viral upper respiratory infections, coughs and colds, or exercise. So I think the consultant was maybe making a best guess assessment. We know that with allergies, as part of the atopic outlook, that asthma is more common, along with hay fever, eczema, and food allergies. So I think it probably was reasonable, given that your consultant likely heard wheeze, and then on that basis gave the usual asthma treatments. And actually, part of the diagnosis is then upon review to see if a child responds to the common asthma treatments, such as the blue inhaler, the reliever, and also the preventer inhaler. So it seems perfectly reasonable. However, I do think that your child should be reviewed. As we've said, a big drive of the National Review of Asthma Deaths, a big recommendation was that children should be reviewed in a specialized clinic, so reviewed by asthma nurses and doctors who have training in asthma care. So I think review would be really important. We're just at the cusp, I guess, of 3.5 that we can start to do more investigations. So that's the conventional or the usual, those are the usual asthma treatments, but I think review would be really important. And I think also, hopefully, you do have a personalized asthma plan. As we've said, that's really important to allow you to facilitate self-management of asthma, which is really recommended now, so that you have a personalized plan that you can understand and follow. I hope I answered the question and maybe talked around it a little bit, but certainly happy to take any other questions.
Could I add to that?
Sure.
I would agree with what Dr. Donoghue has said, and I think what we're trying to do with this campaign is to make sure that children who do have or likely have asthma, that they are properly taught and trained, that their parents are taught and trained, not just given asthma medicine and away you go. So I think you should be asking the doctor that diagnosed the anaphylaxis for you and your child to be seen by the allergy stroke asthma nurse and to be properly educated into what the situation is.